Hello and welcome back to the Learn Medicine Show. In this episode, we're going to dive into a specific type of ECG abnormality, arrhythmias. We'll cover 12 common ECG presentations, the clinical symptoms, the ECG criteria, and etiology for each one. Along the way, we'll use animations to help us understand what is happening in the heart whilst these arrhythmias occur, and how to practically interpret ECG waves. This episode will allow you to get to grips with the fundamentals of arrhythmias, which will help you to save lives. So let's get straight down to business. In the previous episodes, we learned about the components of the normal ECG wave: P waves, QRS complexes, and T waves. We also learned about the segments and intervals. These components can be used to create a structure for working through ECG interpretation. In this episode, we will explore how rate and rhythm can be added to the structure to help analyze arrhythmias. Let's now talk about how to assess the rate and rhythm of an ECG. We'll start by looking at the rate. The first step is to identify the rhythm strip. This is located at the bottom of the 12-lead ECG and is a 10-second recording of lead 2. There are two key ways to rapidly assess the ventricular rate. The first is to count the number of R waves in the rhythm strip and multiply this number by 6. This will give you the rate in both regular and irregular rhythms. For example, if there are 10 R waves in the rhythm strip, the ventricular rate is 60 beats per minute. The second approach can only be used with regular rhythms and involves measuring the RR interval and dividing 300 by the number of large squares between the complexes. In this case, there are 5 squares between the R waves. So when we put this into our equation, we can see that the rate is 60 beats per minute. This is a nice quick way of assessing the rate of an ECG. For example, if there are 4 squares between the R waves, the rate will be 75 beats per minute. And if there are 3 squares, the rate will be 100 beats per minute. The normal rate is between 60 and 100 beats per minute. If the rate is less than 60 beats per minute, this is known as a bradycardia. If the rate is greater than 100 beats per minute, this is known as a tachycardia. Rhythm is calculated by looking at the distances between the R waves. Again, this is assessed in lead 2. If the distances between the R waves are equal, this means that the rhythm is regular. If the distances between the R waves vary, the rhythm is irregular. Irregular rhythms can have a regular pattern. For example, where 3 QRS complexes occur in series, followed by a pause. Notice that this pattern is repeated, making the rhythm regularly irregular. Alternatively, the R waves can be completely irregular, or sometimes called irregularly irregular. Although I have presented the rate and rhythm as separate steps in the ECG interpretation, they are typically assessed simultaneously as part of your ECG assessment. Let's move on now to look at some other rhythms, starting with the most common of all, sinus rhythm. In sinus rhythm, impulses begin in the sinoatrial node, the heart's dominant pacemaker. Impulses are generated at regular intervals, and they depolarize the atria, producing a P wave on the ECG trace. The impulse travels through the AV node and into the bundle of His and right and left bundle branches. Depolarization of the ventricles generates a QRS complex on the ECG trace, and repolarization of the ventricles produces a T wave. The ECG criteria for sinus rhythm is as follows. Using lead 2, there must be a regular rhythm with a rate between 60 and 100 beats per minute. In our trace here, you can see that the R waves are equally spaced, and using our quick rate calculation, the rate is confirmed as 60 beats per minute. To confirm sinus rhythm, the P waves must have a normal dome-like shape, be upright, and precede each QRS complex. So sinus rhythm is really important because it represents normal rhythm. Any ECG that does not fit this criteria is considered an arrhythmia. Before we move on, I want to talk about the mechanisms that drive arrhythmias, as this will help us to understand what is happening when the ECG changes occur. The mechanisms can be broadly divided into abnormal impulse formation and conduction disturbances. Abnormal impulse formation include abnormal automaticity and triggered activity. Conduction disturbances include re-entry loops and conduction blocks. Automaticity can be enhanced where the sinoatrial node produces more impulses, or it can be reduced where less impulses are generated. Alternatively, latent pacemakers, most commonly around the atrioventricular node, can become the dominant pacemaker. These have an intrinsic rate of around 40 to 60 beats per minute. Triggered activity are peaks in electrical activity that occur after a normal action potential. There are two types of triggered activity. These can occur early, known as early after depolarizations, or they can occur later, known as delayed after depolarizations. The impulses produced by these can spread to local myocytes and generate impulses that trigger an arrhythmia. Re-entry is where a large or small circuit is formed by myocardial cells which continuously conduct in a loop. For example, here is an infarction scar with an isthmus, a small channel that runs through its center. This allows for the formation of a re-entry loop around the scar, where an impulse can continuously conduct as different areas of the myocardium become excitable. The rapid conduction through the loop can excite local myocardium, and this drives the arrhythmia. Re-entry can occur on a smaller scale, however, such as with multiple wavelets. These usually originate from a focal point and randomly meander through the myocardium, exciting pockets of cells in a chaotic fashion. Finally, there are the blocks. These occur when impulses cannot pass through the myocardial tissue or through structures such as the AV node, bundle of His, or bundle of branches. There can be complete block, or the myocardial cells can exhibit fatigability. One particular type of fatigue is known as Wenckebach phenomenon, where the cells become progressively fatigued, so much so that they are unable to conduct an impulse. This phenomena is seen in atrioventricular block Mobitz type 1, but is also seen in sinus node exit block. We'll revisit these mechanisms as we move through the rest of the arrhythmias, but for now, let's move on to arrhythmia classification. So now let's turn our attention to arrhythmias. Arrhythmias can be classified by the ventricular rate. A ventricular rate less than 60 beats per minute is known as a bradycardia. A rate greater than 100 beats per minute is known as a tachycardia. In this first section, we'll focus on the tachycardias, but don't worry, we'll come back to discuss the bradycardias later. Tachycardias can be further classified by the duration and shape of the QRS complex. If the QRS complex is less than 120 milliseconds, it is known as a narrow complex tachycardia. A tachycardia with a QRS complex greater than 120 milliseconds is called a broad complex tachycardia. Note that 120 milliseconds is equivalent to 3 small squares wide. So if the QRS complex is less than 3 small squares in width, it is a narrow complex, and if it is greater than 3 small squares in width, it's a broad complex. Let's start by talking about narrow complex tachycardias. These tachycardias have a narrow complex because the electrical impulses are conducted through the AV node and the His-Purkinje system. This allows rapid depolarization of the ventricles and leads to a narrow QRS complex on the ECG trace. Ventricular contraction is coordinated, but the ventricular rates can reach high levels, typically around 140 to 180 beats per minute. This can produce a collection of symptoms, including palpitations, chest pain, lightheadedness, fatigue, and breathlessness. Narrow complex tachycardias rarely produce hemodynamic compromise unless there is pre-existing heart disease, such as heart failure. Let's take a look now at some of the most common narrow complex tachycardias. These include sinus tachycardia, atrial flutter, Atrioventricular nodal reentrant tachycardia, or AVNRT, Atrioventricular reentry tachycardia, abbreviated to AVRT, and atrial fibrillation. The first 4 of these narrow complex tachycardias have a regular rhythm, whereas atrial fibrillation has an irregular rhythm. Let's take a look at each of these presentations now, starting with sinus tachycardia. In sinus tachycardia, electrical impulses originate from the sinoatrial node at a rate greater than 100 per minute. These impulses spread through the atria, causing atrial depolarization and resulting in a P wave on the ECG trace. The impulses travel through the AV node and into the ventricles via the bundle of His and the bundle branches. Ventricular depolarization occurs, producing a QRS complex, and as the ventricles repolarize, a T wave is formed. In sinus tachycardia, we therefore get P waves, QRS complexes, and T waves, but they just occur at a faster rate. To confirm the diagnosis of sinus tachycardia, the rhythm must be regular, meaning that the R waves are equally spaced. The ventricular rate must be greater than 100 beats per minute. The P waves must have normal morphology and precede every QRS complex, and they must be positive or upright in lead 2. Sinus tachycardia can occur due to normal physiological processes, as seen in exercise or anxiety, but they can also be driven by pathological processes such as hyperthyroidism, pulmonary embolism, and infections. Diabetic neuropathy is also a common but irreversible cause. Let's now move on to talk about atrial flutter. Atrial flutter is a narrow complex tachycardia that typically presents with a ventricular rate between 100 and 175 beats per minute. It is a regular rhythm and classically has sawtooth-like flutter waves. Atrial flutter is caused by a large reentry loop that most commonly occurs around the tricuspid valve in an area known as the tricuspid annulus. The loop passes through the cavo-tricuspid isthmus. The reentry loop can be clockwise or counterclockwise. We'll focus on the counterclockwise presentation here, which is otherwise known as typical atrial flutter. The reentry loop causes rapid, regular depolarization of the right atria, producing positive deflections on the ECG baseline. But it is depolarization of the left atrium that results in our negative flutter waves. Impulses are conducted at regular intervals to the ventricles via the His-Purkinje system. This depolarizes the ventricles and produces narrow QRS complexes. Let's take a closer look at the ECG criteria. For atrial flutter, the ventricular rate will be between 100 and 175 beats per minute. In our example here, using the quick calculation method, you can see that the ventricular rate is 150 beats per minute. The rhythm is regular, meaning that the R waves are equally spaced, and flutter waves must be present. The flutter waves should have sawtooth-like appearance, and there should be no isoelectric baseline between each wave. The ventricular response will typically present with a ratio of 2 flutter waves to 1 QRS complex, as seen in our example here. But the ratio can also be 4 to 1, 3 to 1, or 5 to 1. Here is another example where the flutter waves are occurring at a ratio of 3 flutter waves to every 1 QRS complex, a ratio of 3 to 1. Atrial flutter may be idiopathic, but can also be caused by conditions that dilate the atrium, such as atrial septal defects, pulmonary emboli, mitral or tricuspid valve disease, heart failure, or age-related degeneration of the atria. Pericarditis, alcoholism, and thyrotoxicosis may also trigger episodes of atrial flutter. The mechanism for atrial flutter is a re-entry loop that typically occurs in the right atrium around the tricuspid annulus and passing through the cavo-tricuspid isthmus. Up next is Atrioventricular nodal reentrant tachycardia. AVNRT is a narrow complex tachycardia with sudden onset and abrupt termination. It presents with a ventricular rate of 150 to 250 beats per minute. The rhythm is regular, and P waves are generally absent, buried within the QRS complex. AVNRT is caused by a re-entry loop that involves the atrioventricular node. Let's take a closer look at the AV node now. So the AV node has connections from the atria, and it feeds into the bundle of His. There are 2 conduction pathways through the AV node, the slow pathway and the fast pathway. Impulses conducted from the atria move through the fast and slow pathways. As its name suggests, the fast pathway rapidly conducts impulses, so fast that they are able to inhibit and block impulses in the slow pathway. However, the fast pathway has a much longer repolarization time. As a result, if further impulses are produced from the atria, they conduct through the slow pathway and can then be conducted along the fast pathway retrogradely as these cells become excitable. This produces a re-entry loop that fires impulses into the atria and ventricles at high speeds. Because the re-entry loop moves from the slow pathway to the fast pathway, it is known as a slow-fast AVNRT. Let's move back to our ECG trace. Impulses extend from the AV node into the lower chambers of the heart, depolarizing the ventricles and producing a QRS complex on the ECG trace. The impulses also extend into the atria, and atrial depolarization occurs simultaneously with ventricular depolarization. This results in the P waves being buried within the QRS complexes. T waves occur as the ventricles repolarize. Let's take a look at the ECG criteria. AVNRT is a narrow complex tachycardia with a ventricular rate around 150 to 250 beats per minute. In our trace here, the rate is 150 beats per minute. The rhythm is regular, meaning that the R waves are equally spaced. P waves are typically hidden within the QRS complex as atrial depolarization occurs simultaneously with ventricular depolarization. In 30% of cases, however, P waves will occur just after the QRS complex. In this situation, a pseudo S wave will occur in lead 2. If you see a pseudo S wave, you will also see a pseudo R wave in V1 just at the end of the QRS complex. AVNRT is generally idiopathic and occurs throughout all ages, regardless of the presence of existing heart disease. It is caused by a re-entry loop in the atrioventricular node. Next up is the AVRT, which stands for Atrioventricular Reentrant Tachycardia. This is a narrow complex tachycardia with a ventricular rate around 150 to 250 beats per minute. The rhythm is regular and classically presents with retrograde P waves, meaning that the P waves occur after the QRS complexes. In the previous episode, we talked about Wolff-Parkinson-White syndrome, which is a condition where an accessory pathway connects the atria and ventricles. This abnormal connection forms a macro re-entry loop that allows impulses to cycle continuously through the atria and ventricles via the AV node. The re-entry loop can conduct impulses in two directions, but the most common is known as orthodromic, meaning that the impulses are conducted from the ventricles to the atria and back through the AV node. We'll focus on this type here because orthodromic AVRT accounts for 95% of AVRT presentations. Let's take a closer look now at how this occurs. The electrical impulses are conducted through the AV node and the His-Purkinje system into the ventricles. Ventricular depolarization produces a narrow QRS complex on the ECG trace. As the ventricles depolarize, impulses are conducted through the accessory pathway into the atria, leading to atrial depolarization momentarily after ventricular depolarization. This is represented on the ECG trace as a P wave occurring after the QRS complex, and the term used to describe this is a retrograde P wave. T waves occur as the ventricles repolarize. The diagnostic criteria for AVRT is as follows. The ventricular rate should be around 150 to 250 beats per minute. In this example, the rate is around 176 beats per minute. The rhythm should be regular, meaning that the R waves are equally spaced. The P waves should be retrograde, occurring after the QRS complexes. AVRT is caused by an accessory pathway, and these are found in syndromes such as Wolff-Parkinson-White. The accessory pathway allows for the formation of a macro re-entry loop which connects the atria to the ventricles. Our next arrhythmia to review is atrial fibrillation. This narrow complex tachycardia accounts for around 33% of arrhythmia-related hospital admissions, and it carries a 5-fold increase in the risk of cerebrovascular accidents and a 2-fold increase in all-cause mortality. Atrial fibrillation presents with a ventricular rate between 100 and 160 beats per minute. The rhythm is irregularly irregular. P waves are not present, and instead there are fibrillatory waves. There are various pathological mechanisms that can trigger atrial fibrillation. One mechanism involves rapid discharges of impulses around the pulmonary veins. This produces a cascade of random meandering wavelets. These randomly excite areas of the atrial myocardium, and rather than having coordinated atrial contraction, the atrial muscle fibrillates. On the ECG trace, this produces low-amplitude baseline oscillations known as fibrillatory waves. Impulses are conducted through the AV node and His-Purkinje system into the ventricles, and ventricular depolarization produces narrow QRS complexes. T waves occur as the ventricles repolarize. Ventricular excitation occurs in an irregular fashion. Let's take a look at the ECG criteria for atrial fibrillation. The ventricular rate should be around 100 to 160 beats per minute. To calculate the rate for irregular rhythms, you have to use the rhythm strip and multiply the number of R waves by 6. In this case, the ventricular rate is 108 beats per minute. The rhythm is irregular, and fibrillatory waves are present. Fibrillatory waves may sometimes be very fine and not perceptible on the ECG trace, meaning that the baseline may appear completely flat. There are many causes of atrial fibrillation, and the most common causes are hypertension, age-related fibrosis of the atria, conditions which stretch the atria such as heart failure, aortic and mitral valve disease. Obesity, obstructive sleep apnea and psoriasis have also been linked to an increased incidence of atrial fibrillation. The mechanism that drives atrial fibrillation are multiple wavelets. It is worth noting at this point that the loss of normal atrial contraction experienced in atrial fibrillation and in atrial flutter has an impact on normal blood flow in the atria. Let's take a closer look at this. In the left atrium, there is a small pocket known as the atrial appendage. Under normal circumstances, blood flows into the appendage, but coordinated atrial contraction keeps the blood flowing. In atrial fibrillation and atrial flutter, the blood is able to pool in the appendage and a thrombus can form. This can embolize, moving through the circulatory system and block arteries. In this case, you can see ischemic stroke, but embolic disease such as this can also produce ischemia in the limbs and internal organs, such as the bowel. We'll now move on to the broad complex tachycardias. This group of arrhythmias are life-threatening because the conduction in the lower chambers of the heart does not rely on the His-Purkinje system. Instead, conduction occurs from myocyte to myocyte, leading to asynchronous ventricular depolarization. This creates broad QRS complexes on the ECG trace that have a long duration. The ventricles become less effective as a pump, abruptly reducing cardiac output and leading to symptoms such as palpitations, chest pain, lightheadedness, breathlessness, collapse, and potentially sudden cardiac death. These patients will typically present with acute circulatory collapse and require immediate medical attention. The three broad complex tachycardias that we will review here are monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, and ventricular fibrillation. Monomorphic VT is regular, and polymorphic ventricular tachycardia and ventricular fibrillation are irregular rhythms. Let's review each of these now, starting with monomorphic ventricular tachycardia. Monomorphic ventricular tachycardia presents with a ventricular rate of 100 to 250 beats per minute. The rhythm is regular, and there must be 3 or more abnormally shaped QRS complexes in sequence. Each of these must have a duration equal to or greater than 120 milliseconds. Ventricular tachycardia can be caused by abnormal impulse production or re-entry. In this case, we'll focus on re-entry as the driving mechanism. This most commonly occurs around injured areas of the myocardium caused by ischemia, such as an infarction scar. The re-entry loop produces waves that pass through the ventricles. This produces broad complexes on the ECG trace. As the wave front moves towards the right ventricle, there is an upward deflection on the ECG trace, producing an R wave. And as the current moves back towards the left ventricle, an S wave forms on the ECG. P waves may sometimes be seen, but they are very difficult to identify. The asynchronous depolarization across the ventricles makes contraction less coordinated and can lead to significant reduction in cardiac output and hemodynamic compromise. So let's take a closer look at the ECG trace and the diagnostic criteria. Monomorphic ventricular tachycardia has a ventricular rate between 100 and 250 beats per minute. Using our quick calculation method, the number of large squares is 1.2. Note that the value of a small square equates to 0.2. So when we put this into our equation, the rate here is 250 beats per minute. The rhythm is regular, and there must be 3 or more abnormally shaped QRS complexes that have identical morphology. Small variance in appearance is allowed, but they should be generally the same height and shape. The complexes should all have a duration that is equal to or greater than 120 milliseconds, which is 3 small squares wide. If we select these 3 complexes, you can see that they all have a similar shape and size, and if we zoom in, you can see that their duration is around 7 small squares each. The causes of ventricular tachycardia include ischemia, hypotension, hypokalemia, dilated cardiomyopathy, and hypertrophic cardiomyopathy. The mechanisms that drive the arrhythmia include abnormal impulse production or re-entry loops around injured myocardium. Next up is polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia presents with a ventricular rate between 100 and 320 beats per minute. The rhythm is irregular, and there must be at least 3 abnormal QRS complexes in series with varying height and morphology, and each must be equal or greater than 120 milliseconds in duration. In monomorphic ventricular tachycardia, we had a single foci generating a wave of electrical activity that moved through the ventricles. In polymorphic VT, there are multiple ectopic foci. Impulses produced by these different foci generate complexes of varying amplitude and morphology. Let's take a closer look at the ECG trace. In polymorphic ventricular tachycardia, the ventricular rate should be between 100 and 320 beats per minute. In this case, to calculate the ventricular rate, we have to count the number of R waves and multiply by 6. There are 50 R waves in total, so this gives a ventricular rate of 300 beats per minute. The rhythm is irregular, but this can be difficult to appreciate in fast arrhythmias because the RR intervals become very short. There needs to be 3 or more abnormal QRS complexes with varying amplitude and morphology, and they must have a duration equal to or greater than 120 milliseconds, which is 3 small squares. If we select these 3 complexes, you can see that they have varying height and morphology, and the duration of each complex is greater than 3 small squares. The most common cause of polymorphic ventricular tachycardia is ischemia. It can also be caused by prolonged QT interval, which produces a polymorphic ventricular tachycardia known as torsade de pointe. Torsade de pointe is a ventricular tachycardia characterized by QRS complexes of changing amplitude that appear to twist around the isoelectric line and occur at rates of 200 to 250 beats per minute. The mechanisms that drive polymorphic ventricular tachycardia is re-entry around injured myocardium or abnormal impulse production from multiple foci. Now let's turn to our final broad complex tachycardia, the most deadly of all, ventricular fibrillation. This presents with a ventricular rate from 150 to 500 beats per minute. It is an irregular rhythm and produces an ECG trace with irregular waves of varying contour and amplitude. Ventricular fibrillation is driven by a mother rotor that likely arises from a focal trigger, such as ischemic tissue. This rotor generates a surge of complex wavelets that move chaotically and asynchronously through the ventricles. This chaotic depolarization of the ventricles results in complete loss of coordinated ventricular contraction, and as a result, the ventricular muscle fibrillates. This results in significant hemodynamic compromise. This means the heart is not pumping out enough blood to sustain vital organs, including the brain, and this produces irreversible brain damage within 3 to 5 minutes unless corrective measures are undertaken promptly. So let's take a look at the ECG and the criteria. The rate should be 150 to 500 beats per minute. The rhythm is irregular, and the trace shows irregular waves of varying contour and amplitude with no P, QRS, or T waves. If you cast your eye along this trace, you will note that there are no features of P, QRS, or T waves, and the complexes are haphazard and chaotic. The most common cause of ventricular fibrillation is ischemic heart disease, or more specifically, an ischemic event. Dilated cardiomyopathy or hypertrophic cardiomyopathy may also cause this arrhythmia. Ventricular fibrillation is driven by coexistent multiple complex wavelets that are produced by a mother rotor. Now let's turn our attention to the bradycardias. Bradycardias are arrhythmias that have a ventricular rate less than 60 beats per minute. They generally arise due to failure to generate or propagate impulses from the sinoatrial node. They can also be due to blocks in the atrioventricular node or the bundle of His, or may occur due to a latent pacemaker taking control of the heart's impulse production. In most cases, bradycardias will not cause any significant harm, even when the ventricular rate is in the 40s. However, bradycardia can cause a reduction in cardiac output, and for some patients, especially those with existing comorbidities such as heart failure or valvular heart disease, may present with symptoms such as fatigue, dizzy spells, chest pain, syncope, or hemodynamic collapse. Let's take a look at some of these presentations now, and these will include sinus bradycardia, sinus node dysfunction, atrioventricular blocks, and junctional escape rhythms. Let's start by looking at sinus bradycardia. Sinus bradycardia presents with a ventricular rate less than 50 beats per minute. It has a regular rhythm, and classically the P waves should be monomorphic, positive in lead 2 and precede each QRS complex. Sinus bradycardia initiates in the sinoatrial node, where impulse generation is reduced. Impulses are conducted through the atria, producing atrial depolarization and a P wave on the ECG trace. The impulses are conducted through the His-Purkinje system, and depolarization of the ventricles produces a narrow QRS complex. Ventricular repolarization produces a T wave on our ECG. To confirm the diagnosis of sinus bradycardia, there must be a regular rhythm, meaning that the R waves are equally spaced. The rate must be less than 50 beats per minute. Using our quick calculation method, you can see that the ventricular rate is 42 beats per minute. The P waves must be normal shape, positive in lead 2, and precede each QRS complex. There are various causes of sinus bradycardia, and these are usually grouped into physiological causes such as trained athletes, increased vagal tone during sleep, or carotid sinus hypersensitivity. Pathological causes include medications which slow impulses from the sinoatrial node, such as beta blockers or calcium channel blockers and digoxin. Heart conditions such as acute myocardial infarction, sick sinus syndrome or heart block, and other medical conditions such as hypothyroidism, cholestatic jaundice, raised intracranial pressure, and cervical and mediastinal tumours. Now let's turn our attention to sinus node dysfunction. Sinus node dysfunction is a term used to describe a collection of presentations where there is impairment to generate or propagate impulses from the sinoatrial node. These include inappropriate sinus bradycardia, sinus arrest, sinus node exit block, tachybrady syndrome, and chronotrophic incompetence. Let's take a look at each one of those now. Inappropriate sinus bradycardia. This is a sinus bradycardia caused by pathological processes. The criteria for this condition is a rate less than 50 beats per minute, regular rhythm, and P waves with normal morphology, upright in lead 2, and preceding each QRS complex. Sinus arrest. In this presentation, the sinus node fails to discharge an impulse. The diagnosis is confirmed if the duration between the start of the P waves is greater than 2 seconds, which is 10 large squares. Syncopal episodes caused by sinus arrest are known as Adams-Stokes attacks. Sinus node exit block. This describes the failure of the sinus node to generate an impulse. This occurs in a similar way to the AV node blocks, where the cells in the sinus node become fatigued and after a number of impulses fail to propagate. In this example here, you can see that 3 P waves are generated regularly, but the 4th P wave is not generated, and subsequently there is no QRS complex or T wave. Tachybrady syndrome. In this condition, a tachycardia, most commonly atrial fibrillation, terminates, but the sinus node is unable to produce an impulse, and subsequently there is a prolonged pause which creates a bradycardia and can lead to syncope or collapse. Finally, there is chronotrophic incompetence. This is a failure of the sinus node to produce 80% of the expected maximum heart rate during exercise. The maximum heart rate is calculated using the following equation, and patients perform a treadmill test to determine whether the heart rate is able to rise adequately. The etiology of sinus node dysfunction includes intrinsic causes such as age-related fibrosis, ischemia, cardiomyopathy, or other infiltrative diseases. Extrinsic causes include drugs that slow production of impulses in the sinus node, autonomic dysfunction, hypothyroidism, and electrolyte abnormalities such as hyperkalemia. Atrioventricular blocks. The atrioventricular blocks are caused by abnormal conduction through the atrioventricular node and the bundle of His. We have covered these in a previous episode, so I'll put a link at the top of the screen now should you wish to go back to these. Bradycardias in this group of conditions are seen more prominently in Mobitz type 2 and third-degree heart block. Finally, let's talk about junctional escape rhythms. These present with a rate of 40 to 60 beats per minute. They are regular and classically present with absent or retrograde P waves. In our example here, the sinoatrial node is no longer able to generate impulses. Instead, a latent pacemaker takes control of the impulse generation, and these are typically located around the atrioventricular node. These latent pacemaker cells produce impulses at a rate of around 40 to 60 beats per minute. The impulses are conducted via the His-Purkinje system, so when ventricular depolarization occurs, the QRS complex remains narrow. But because there is no atrial depolarization, there is no P wave preceding the QRS complex. Repolarization of the ventricles produces a T wave. The ECG criteria for this condition is a regular rhythm with a ventricular rate of 40 to 60 beats per minute, with absent or retrograde P waves. The causes of junctional escape rhythms include ischemia, digoxin overdose, theophylline, hyperkalemia, and perimyocarditis. This brings us to the end of this episode of the Learn Medicine show. The next episode will be about the cardiac axis, so make sure you subscribe and hit the bell to prevent you missing out on this one. It's going to be great. As always, please let me know what you think to the show. Leave a comment, like the video, because that really helps the channel. And thanks for sticking with me on this series of ECG interpretation. Thanks for watching. I'll see you in the next show.